my slide? Do you see my slide?
Yes, Christine.
All right, and Dr. Kumar and I would like to thank you for inviting us to talk about Q-TIP and our journey to integrate behavioral health care across several pediatric practices in South Carolina. I will talk about the framework that we use to do the work we do with our pediatric practices, and Dr. Kumar is going to wrap up with talking about his journey as a pediatrician integrating behavioral health into a busy pediatric practice. For those of you that do not know me, I'm Christine Hobbs, and I'm the Mental Health Integration Coordinator for the Q-TIP program. And Dr. Ram Kumar wears many hats, but today he is wearing the hat of the Q-TIP Medical Director. Before I talk about Q-TIP though, I wanted to start by thinking about what foster care means. Not as an exercise in semantics, but really to focus our time here together. Using the verb tense of foster and the noun tense of care, we can replace foster and care with words providing more intense descriptions of what our roles are as providers of care to children who are in foster care, as well as providers of care for those who provide care for them and support them. We encourage their safekeeping. We promote appropriate supervision. We strengthen the bonds of custody. We nurture for their protection. We assist in their guidance. And the verb-to-verb tense describes even more actively our role in caring for our children in foster care. You are taking time to bother to bring up other people's children. You are our children. You are looking after those rearing them. You are helping to take care of raising them. You provide another set of eyes to look after them and protect them. You are nurturing them to guard against future challenges. If one of these descriptions really speaks to you, I would encourage you to write it down. That's what the Post-it note image is for. If we were together, I would have given everybody a Post-it note, but write it down and think of your role in the system, because the system that we call foster care is really made up of all of the actions that each one of us takes when we provide care to our children in foster care and to care to those who care for them. And in referring to children in foster care, I usually do refer to them as our children because I do believe that they belong to all of us. And how do we do this in a pediatric office? For the past 10 years, my job has been to help pediatric practices in South Carolina fully integrate behavioral health into their primary medical home. My framework for doing this has been the American Academy of Pediatrics toolkit addressing mental health concerns in pediatrics. And in the toolkit, they divide our work into 5 categories: community resources, healthcare financing, support for children and families, clinical information systems and delivery redesign, and decision support for clinicians. Before I jump into our lessons learned, I wanted to provide a touch of background. For those of you who may not know, Q-TIP stands for Quality Through Technology and Innovation in Pediatrics. And we are an ongoing collaboration of the South Carolina chapter of the American Academy of Pediatrics, the South Carolina Department of Health and Human Services, and pediatric practices who self-select from across the state to participate in our project. We currently have 26 practices participating. Over the years, this is a slide of the practices who have participated. And as you can see, we're clustered in our major communities, but we are spread out across the state as well. And each practice has needs based on where it sits in our state, as well as what community it sits in. And that leads us to our first category, community resources. And our lesson here comes from Maya Angelou. I have learned that I still have a lot to learn. Many South Carolina communities are rich with resources, but sometimes they do seem hidden. To uncover these gems in 2011, we started community visits, literally. We loaded up in my mom van and we were off visiting our community partners. Our first community meeting was a mental health center. And there I learned that my practices did not have the correct fax number to send over referral forms. Well, that's kind of critical if that's how the mental health center gets their referrals. So as a result of that visit, that referral problem was solved. In another community, we found out that if our pediatric practice provided a letter stating the size of the family to the family to take to the local food bank, the food bank would issue them 3 days of emergency food without any other paperwork. That expedited the resources for those families. If you were in my practices, I would start by wanting you to know what resources are available to help you support care for our children and families who are within the foster care system. Some of these are new to us. Select Health has upped their game around care or case management services to provide more opportunities to link our children with needed services. DSS has upped their game with some of their services around the state and providing regional nurse managers who can help coordinate care. And they also are hiring, if they haven't already, we'll be hiring education liaisons to help us with the educational needs of our kids. In addition, DSS staffs cases weekly or monthly. And if you have a case that you're really struggling with, you can offer to bring that case to their case staffings. WIC is a food resource. Any child in foster care automatically qualifies for these food resources. BabyNet is an option for all of our children in foster care to be referred and screened. And then in certain communities, there are also clothing closets and parenting workshops. And as I said, we visit with our community providers. Here are pictures of our visit. This is a food bank that we visited. Here's an alcohol and drug center that we visited. And here's a local library. In our community visits, I ask 4 questions. What do you do? Who do you do it for? How do we get the right kids and families to you? And if we share kids, how do we share appropriate information? And if any of the resources that we just talked about are new to you, I would encourage you to ask those questions of those resources, whether it be a DSS resource, a Select Health resource, or any of the others that we might talk about. Things have changed, and the only way we know what those changes are is to ask. Moving to healthcare financing, my lesson has been that people pay the doctor for his trouble, but for his kindness, they will remain in his debt. Seneca the Younger. We need to make sure that the business model works for the pediatric practice if we're asking them to do a task, because if they don't get paid, the practice will not survive and we will not have that service. When we started, billing and coding and screening was not well defined. And when we promoted the idea around screening, I learned more than I ever wanted to know about billing, coding, and policies around screening. But that work was necessary for the screening to work in our practices. As a practice providing care to children in foster care, if you were my practice, I would want you to know how to bill correctly for the first visit that the primary care physician has with that child in foster care. Not the first visit for the child who is in foster care, but the first visit where you are the provider of care for that child in foster care. And the nuance would probably be around your practice, but you would have to figure those things out, and that is way above my experience or information. But if you'll look in the chat, I have included the link to the Medicaid bulletin. I've included the wording around the bulletin so that you can follow up with your practice billers and coders and make sure that you are screening and that you are coding correctly for those visits. I would want to make sure that you know the nuances of screening for developmental screening, social determinants of health screening, trauma screening, substance use screening, and behavioral health screening. And I would also encourage you, my practices, to use community extenders to support their work whenever possible, freeing up their staff from responsibilities that others could just as easily do. Support for children and families. I tell my practices all the time, you are only going to be perceived as family friendly as your least family friendly staff member. So when you're providing care and support for all children and families, that's going to be the case. But for children who are in foster care and for the families who are caring for them, using some trauma-informed care guidelines is essential, and Tracy went over some of those for us earlier in this session. Having toys or stories for families that come in. How many families do you have that come in and don't have something to entertain their children, and they've had their children their whole lives? Imagine if you just got a child yesterday and now you're bringing the child to the doctor's office. Providing flexibility in how you schedule those appointments. Tracy and some others have talked about that as well. Having care coordination and care managers among other providers to help you segue that child from your service to the next service. And for our children who are in foster care, there may be different visit flows for those children, and those are things that your practice would have to sort through. We were really lucky and Q-tip, because around the same time we started our project, the National Alliance on Mental Illness had surveyed over 500 families to ask them what they wanted from their primary care providers. And what those families said is that they wanted resources on information on what their child's disability or challenge may be. They wanted practices to provide screenings and questionnaires. They wanted a private place to talk to the doctor for either the parent or the child. And they wanted the doctor to offer them hope. And they also wanted the doctors to not be judgmental. So we use those ideas as some of the framework for how we looked at how we were going to support children and families. And these are some ideas that you may or may not want to think about for how you do that work. And everything that we do is under the idea of systems redesign, which is a very fancy word for quality improvement. No one caring for children with multiple needs is sitting around with extra time waiting for something to do. In order to do this work, we must structure our processes to allow us to meet the needs of our patients and their families. And that is always a careful balance between quality improvement and creativity. Maya Angelou says you can't use up creativity. The more you use, the more you have. And everything we do with Q-tip is under the umbrella of quality improvement science. We use the model for improvement for small plan, do, study, act cycles of change. We try something, we study it, we change it, or go back and redo it based on what we found. This is essential as you look at your practice flow and information exchange. Our practices have work process flow, such as increasing vaccination rates, improving HEDIS scores for well child visits, and around when and how to give screenings. Some give a clipboard to both the child and the parent. Some do it at weigh-in when the child is away from their family. Some use online processes. But we have learned that quality improvement works. And how did we bring this all together? If you were to look at our screening uptake, the green line is the percentage of practices that were using that type of a screener routinely when we started our work in 2010. If you look at the orange bar is the percentage of practices that were using that type of a standardized screener for their practice in 2019. I use 2019 data because Shazam 2020 was kind of a wacky year. But looking back on that, originally we had 17% of our practices doing standard developmental screening and 80% 9 years later. 28% doing routine standardized autism screening, 100% in 2019. 17% screening for postpartum depression screening, which is the social determinant of health for our population, 97% do that now. And you can read across there, but no one was doing social determinants of health screening. No one was using the CRAFT screening for standard substance use screening, and no one was doing trauma screening. So putting those policies in place, supporting kids and families, knowing what our community resources are, because if you screen, you need to know where to send that child. All of those pieces built in together, and this is just one of the many ways that we can look at how all of those processes fit together, which brings us to our last category in our framework. Many of us my age grew up with Mr. Rogers, and Mr. Rogers taught us so many lessons. But one thing he said that I love is that we live in a world which we need to share responsibility. It's easy to say it's not my child, not my community, not my problem. And then there are those who see the need and respond. And I consider those people my heroes. And you're on this call today as my hero because you're willing to care for our children who are in foster care who may come with nothing other than themselves to a visit. And then you've got to use your best clinical judgment to determine how you're going to provide care for that child or what's going to happen going forward. And so in my 10 years with being with Q-tip practitioners, many of my pediatricians had little training in mental health. And all of them still acknowledge the lack of child psychiatrists and mental health specialists in South Carolina. And some of those pediatricians responded by enhancing their skill set and working to the top of their skill set to address these needs. And when I'm asked, how do you teach pediatricians to do this? My response is any, period, way, period, you, period, can, period. Physicians didn't get to be physicians because they don't know how to learn new things. But sometimes you have to coach it in a way that encourages them. So if you were in our Q-tip, we have learning collaboratives where we get opportunities for our practices to get together to learn from experts And sometimes those experts are very much themselves and share the information that they've learned across the board to their peers and partners. Our community partners, such as mental health, have opened up their training to us. We have many AAP resources that are available to us and to you. And we started most recently, we started a Wednesday wellness series where we look at a 20-minute video and then discuss that video in relation to the children that we serve. I have learned to go where the energy is, and the energy brings physicians who want to share and learn. If you were my practices, these are some of the resources I would want to share with you to help in your decision making. Attending these echo sessions, and I see several of my doctors are on this. Study the AAP resources. They have resources for children, families, and specifically for children and families in foster care. Read a book about what it's like to be a child in foster care, what it's like to be the parent of a child who is in foster care, both a biological parent and a foster care parent. Find a mentor, because this is not going to be easy work. In our Q-tip program, we're allowed to use Dr. Ketpal for consultation, but any practitioner providing care for a child in foster care is able to access Dr. Ketpal for consultation. And I know that she is on our call as well. Also, the MUSC Foster Care Clinic, which I saw Tracy and Dr. Wallace are on this call, they've partnered up with DSS to be a resource for all of you, a resource around technical assistance, case consultation, as well as finding resources for your children, your youth, and their families. So before Dr. Kumar takes the mic, linking back to where we started from, there's no way I can share what we have learned in 10 years of working with pediatrics, collaborating with multiple payers and community partners to you in 10 minutes. However, I can share that pediatricians join these types of sessions because they want to provide the best care to our children and our families in South Carolina. And that care for our children in foster care is action-based. Please think about what your role as a provider of care to children, parents, and colleagues in this system will be. Think about what words really speak to you, and I would encourage you to write those down on a sticky note to remind you of your very action-oriented role in this system of fostering and caring for our children. And now I'll introduce to you Dr. Ram Kumar, who is our medical director at Q-tip.
Thank you, Christine. So I just wanted to add my own personal experience, my journey as a pediatrician, and how I went from, not having, like Christine said, enough training in dealing with mental health to where I am now. We know that 1 in 5 children have some kind of mental health issue that needs to be addressed. And this is pre-COVID and pandemic. So I could only imagine that that number is going to keep going up. And when it comes to the children in foster care, we know at least 2/3, so even 66% of them are going to have a mental health issue that needs to be addressed. So I don't know about you, but we don't have enough psychologists or psychiatrists to deal with that kind of number. So the only way that can happen is if the pediatricians become more competent in dealing with mental health issues. So that's one of our goals in Q-tip is making the Q-tip practices more mental health competent. So the way that we did it is that we started out with 1 block, and then you cannot go all the way from nothing to a castle, and it has to be built 1 block at a time. For me, it took about 10 years. We started Q-tip in 2011, and I'm still on the journey to getting more competent in caring for mental health issues. Next slide, Christine. I just wanted to share some of the lessons that I've learned personally, and also in being part of the Q-tip practices. So the one thing that Christine will tell you, and I'll tell you, is that the Q-tip practices, it's not one size fits all. So we have some practices that have like 1 provider and 2 front staff, and we have some practices who have academic setting, all the resources that they can have. So it is very important to cater what you want to do and what is a definition for mental health competency based on your practice size and your resources that's available. The most important thing is all about the prep. So if you're going to implement a screening or any other process in your practice, make sure you do enough preparation. That means you research on exactly what screening tools that's available, how it's going to be implemented in your practice, how is the workflow going to be. In fact, if you want to do it, like I've done it several times where it's just that one physician is piloting it before you roll it out all practice wide. And make sure that you have a plan and what you're going to do with all the positives. So most important thing with the screening and the hesitancy in screening for mental health and behavioral health issues is what do you do if there are positives? So make sure you have a plan for that. So personally, I've done like algorithms where you have a sheet that'll tell you exactly what happens if the screen's positive so that everybody is comfortable following that. And gather your resources. That's where Christine comes into play. She has helped all the Q2 practices so much in finding the resources. It's always been there. We just didn't know about it. So once you have the resources, again, you'll be more comfortable so that you can link your patients to those resources. And Christine talked about the PDSA cycles. So everything that we do in QTIP is in small quality improvement cycles. So when you're implementing a screen, you do multiple PDSAs before it fully integrated in your practice. The most important thing that I figured out is that you need to have staff buy-in. For example, one of our Q2 practices, there was a MA. She was fully bought into the QI component of the QTIP, and she did such an amazing job in their practice implementing QI cycles. And she made every one of them, including the front staff, do a QI improvement project every month. And again, we found like when we do our projects, we found that it's not enough just involving the clinicians. You get the whole staff to educate about them. For example, when we did the suicide prevention project, or even before that, we involved everybody in the staff. And if the staff knows that this is something that's important for their children, they're going to have an extra buy-in, and they'll be like extra motivated to implement what you're trying to do. Next slide, Christine. The most important things is just my personal opinion is just for mental health competency. These are the things that you need to be doing. Screening. I don't think anybody, I've not seen, I've seen some, but most of the kids, they're not going to come out and tell you that they have an issue, especially a mental health issue. So unless you ask them in the most evidence-based way it's possible, you're not going to get the right answer. So screen, screen, screen. So I went from, when we started Q2 practices, we did not do a single standardized screen, whether it's be for a developmental or for behavioral emotional. Now to the point where it's almost like every age that they come in, we have some form of developmental or emotional and behavioral screens we are implemented. Get informed and educated. That's again has been my personal journey of myself. We started QTIP, and I have gone through mini fellowship through the USC, where I went and looked at the various types of learning disabilities. How do you manage complex ADHD patients? And that's one of the things that Christine talked about. We strive to do is just give more information and education for the pediatricians. Know your resources and partners. Again, Christine talked about that eloquently. So most important thing is to find out that what your local resources are. And last but not the least, the most important thing that QTIP does is helps us collaborate. So before QTIP, I don't think I've had this much of collaboration with my fellow pediatricians. So and we strongly believe in learning from others and not reinventing the meals, so that if somebody has implemented a screening protocol in one practice, there's no need for your practice to completely reinvent the wheel. Just learn from their successes, learn from their challenges. And that has been the most important motto for QTIP. So with that, I'll stop and we'll take any questions or comments or suggestions.